So Declan, I was recently at ASCO GU in San Francisco, one of our favourite meetings.
Yeah.
And some great data there, exciting new trials that read out and were presented by, some well-known people, some of our friends. And we got some of the latest highlights in the recent podcast that we put out.
I loved your podcast. If you hadn't seen it,
It was fun.
It was just on the feed from last week. Renu took a camera and some microphones with her and ran around the place chatting to lots of people at ASCO GU, and it's great scenery. You went for a run with Tyler.
Oh, I did. Those hills of San Francisco, I survived. It was really fun. But does the name Vinay Prasad mean anything to you?
Vinay Prasad, yes, Dr. Prasad. He's been on the podcast before.
He has, yeah.
It does. I must say, if you say the name to me, I smile. I go, Vinay, I like Vinay Prasad.
Yeah, we know Vinay pretty well, and he's got his own podcast, the Plenary Session, and he's put out a couple of recent podcasts highlighting some of the deficiencies in the big trials that were presented at ASCO GU, namely Contact-02 and Keynote 564. Big highlights of the meeting.
They really were, and for those of you who don't know him, he's a practicing haematologist, oncologist. He's a professor of haematology and epidemiology at UCSF in San Francisco. He's published 400 or 500 papers, a number of books. His areas of interest are obviously oncology, but also health policy, trial design. He doesn't do clinical trials. He's very upfront, but he has a real interest in trial design and health policy. And would it be fair to say he's outspoken on his thoughts?
He definitely has his own unique style.
He does. And for that reason, when Renu mentioned the name Vinay Prasad to me, I smiled. I'm like, Vinay, we've met him before. We met him in person actually over there one day, didn't we?
We did.
When you say it to other people, they will scowl, or they will, they will grit teeth, or they will say, foul language will come out if they will say that. Yeah, blah,
he's
blah.
very divisive, and he can be very inflammatory, and he does have his own way of putting out some very good points, but sometimes it's covered in not candy.
So what we did on this podcast today is we invited Vinay back on for a chat. He spoke with us last year or 2 years ago about the PROfound study, but we wanted to speak to him about these two recent ones, and we wanted to challenge him a little bit as well, I suppose, on some of the style of his communication and the way it does certainly ruffle some feathers.
Absolutely.
So hopefully you'll enjoy this, our chat with Dr. Vinay Prasad. So Renu, shall we go and talk to our fantastic guest?
We should. There he is. Good to see you, Vinay.
Dr. Vinay Prasad, thank you for joining us.
It's good to be here. It's good to be back.
And as always, lovely setup on your end. Your studio is amazing. You've got, a fantastic camera and audio. It looks good.
Thank you so much. Yeah, we're trying to copy you guys. You've got a great setup as well.
As we said in our introduction earlier on, Vinay has an enormous profile doing his podcast. And based on his many publications, hundreds of publications, the book Malignant, of course, which is a great read, but his podcast, Plenary Session, is really, really a high-quality broadcast. And that's what we want to talk about today, two of his recent episodes focusing on two big trials at ASCO GU. And you were at ASCO GU.
That's right, yeah. So, it was a lot of data presented at ASCO GU, and some of it very controversial. But, yeah, Vinay's really taken those main studies. I think some of the keynote trials, Keynote 564, of course, was one of the highlights of ASCO GU, and Contact-02.
So we're going to talk about those two trials, or talk about Vinay's, we think, extremely valid points when he criticizes these trials. But before we do, Vinay, of course, you have a big social media profile. You've like 250,000 Twitter followers, and we can see that when you do make these criticisms, it does put some people's noses out of joint. And Renu, we were just looking at some of the reactions to this. Is the
I think some of the reactions are as colourful as Vinay's critiques.
Go on, what's this one?
So we've got a tweet here from Scott Egner. OS data on adjuvant pembro for resected RCC has been presented at ASCO GU. Scientifically valid and important points worth a listen, delivered in prototypical, blustery, obnoxious, condescending, self-serving manner by Vinay Prasad. But scientifically valid, so very balanced tweet there.
You take what you can get, okay.
And we all love Laura Bukovina, who said, agreed, valid points, wishes delivery was better. A better approach would be to discuss with the PI directly on the podcast. I don't know if that's feasible, Declan.
Not
seems
if
like
you've listened to his original podcast.
You guys love to
and
come
then-
on podcasts and face these tough questions, I can tell you.
Yeah, I'm sure.
absolutely.
They love to come. They love to come.
And Alex Kudikov, I appreciate your Vinay's book, Malignant, and often read his subtract. However, this is way too personal, accusatory, and veers into conspiracy territory. Dr. Chueri does not deserve this, not even close.
And those are all urologists. They're all friends of ours, close friends of ours. So I think the medoncs don't even get on anymore and make a comment. But before we talk about the two trials, we really want to talk about your criticisms of them. But, how do you react to those sorts of comments and criticisms of, I suppose it's mostly your style. And people aren't criticizing the substance, it's the style and the personal attacks that some people see it as, Vinay.
I guess in my mind, I think that's emblematic of the core problem, because we're going to talk about these two studies. In one study, I'm going to argue that the control arm of Contact 2 received an unethical control arm. Hundreds of people are randomized to drugs that are substandard. You wouldn't give your own father, that is just grossly unethical. So what is worse? The fact that we did that and all these cancer patients died not getting chemotherapy. Okay, is that worse, or my tone? Is my tone worse? And I think many people think it's my tone. And that is the root problem in oncology. How are we going to make progress on control arm quality, on post-progression therapy, if anyone who says anything gets criticized for tone? Now, of course, I am who I am. My tone is my way. But there are commentators in oncology like Mani Mohyuddin, who's extremely polite, the sweetest, nicest. He says the same points, but very polite. He also gets the criticism of, the tone police. So I think it's an easy way to avoid the issue that these clinical trials are not serving patients. They're not serving the public. They have gross deficiencies. And when the history books are written, people are not going to be talking about my tone. They're going to be asking why we allowed these trials to continue in the 21st century. That's going to be the problem. So
I agree with that.
Good rebuttal.
But what if I said to you that, Vinay does it deliberately? He does it because that's part of his shtick. He's like one of these populist politicians who says and does these things just to bring the attention in, that it's just part of the technique of drawing attention to it.
Is that right, Vinay? Is it that you just don't care and you're just speaking your mind? Or is it a way to get attention to your points?
Yeah.
That's a good point. But here's what I would say. I don't think it's that. I think it's this. Most people cannot speak as frankly as I, because most people have one foot in the system. Most people want to be critical of the trial, but they're also running a trial with the same company, Exelixis, on the other side. Most people want to be critical of Keynote 564, but they have to deal with Merck.
Yeah.
I don't. I'm a professor of epidemiology. I do see clinical. I have a practice. I see patients every week in clinic. I do it at the county hospital where it's sort of almost pro bono. I do it, our services we provide to patients are pro bono. I do inpatient solid tumor, liquid malignancy. I'm free in a way. I'm not indebted to companies. I don't do any consulting for companies. I'm not running any clinical trials. If everyone were in my position of independence, more people would be as outspoken as I am. But people can't. And I think we see a few people. Aaron Goodman, for instance, at UC San Diego, he's outspoken about myeloma, different field, but he's also sort of independent. He doesn't run trials himself. So to me, and then the other thing is we have to be honest, which is that in any system where there's thousands of oncologists, people's personalities are different. Some people are more blunt and some people are more, reticent. You're going to get the whole range. And where does the audience go? The audience goes to people who they think are making good points in a well-delivered manner. And that's really where the audience goes. And so, what do you want? It's just the nature of any ecosystem where there's lots of voices talking.
Fair
Totally
enough.
agree. And actually, you can see it in your YouTube channel. These posts are always very, very popular. And I enjoy reading the comments underneath as well. And you can see that this all strikes a chord. That,
Absolutely.
So,
And I think we were speaking about this before, Declan. I mean, one thing that we really do appreciate is that you put a lot of work into these podcasts. I mean, you really dissect down those trials, you get into the nitty gritty of it, and you back up each of your claims.
Yeah, we have we publish 60 papers a year in healthcare policy and these kinds of issues. Malignant goes into this, but everything we're talking about here, control arm quality and what therapy should come after progression, these are common intrinsic issues. And everyone, we published original research in one, I think, JAM Oncology, the other, I think, in the European Journal of Cancer, where we're documenting this is a problem across oncology trials. 20, 30% of oncology studies have this problem where they're not using appropriate control arms and they're not giving good care on the back end. And we'll talk about what it means for these two trials.
And this is the second time that Vinay's been on our podcast. The last time was for the Vision trial and your critique of that. So this time it's Contact 02 and Keynote 564.
actually, it was the Profound study. Didn't we put that in the title
We
of the
did,
podcast?
yeah.
I think I've been on twice, Profound and Vision.
Yeah,
Vision with Michael Hoffman. Yeah.
Yeah.
Yeah, that's right. So look, let's go to Contact-02.
Yeah.
So this got a lot of attention. It was a big study, kind of very eagerly anticipated, because there's still this lingering question about the role of immuno-oncology in prostate cancer, which, you know, everyone knows my view on this. It's a total waste of time. We should not be doing these widespread unselected trials using a therapy that has minimal chance of benefit and exposing all these patients to blah, 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 blah. But yes, so this was a big phase 3 randomized trial being read out, eagerly anticipated in the progressive metastatic CRPC setting. Patients were all, I think, on an AR pathway inhibitor and had progressed.
Correct.
Basically. And they were nasty cancers. 40% had visceral metastases. So these patients are all progressing and they need extra treatment. And the setup of the study was they were randomized to either basically continue on an AR pathway inhibitor, switch over to one or the other.
Switch, yep.
Yeah. So in other words, not change to chemotherapy or, well, I suppose radioligand therapy wasn't out then, but chemo certainly was. Or to go on the intervention arm of atezolizumab.
Cabozantinib.
Yeah, Cabo
Atezo, yeah.
So shall we go straight to you first of all and say, what do you think about that trial design and about the active agents? And then, of course, we want to hear the thoughts on the control arm and on censoring and all these other really good points you made. But your first overall view. And we'll put links, by the way, in the show notes to Vinay's full plenary session podcast on this.
I mean, the first point is that in a perfectly functioning oncology ecosystem, Cabo and Atezo would be abandoned in prostate cancer. These are both drugs that have failed as single agent drugs. They have low activity. They're not that promising. Combine them together, and not only they're not promising, you have terrible toxicity. So how can you eke out a win with terrible drugs, low activity, not very promising, have failed themselves in randomized controlled trials? We may remember about cabozantinib famously failed after some JCO, early excitement in the JCO in the middle of last decade. You take these two drugs, the only way to eke out a benefit, not even on OS, but on PFS, is if you go up against the absolute worst control arm you can think of, which is giving abiraterone to somebody who progressed on enzalutamide. That is absolutely unacceptable. It's the worst option, especially when you can reach for docetaxel or cabazitaxel or, lutetium-177 PSMA, as you can now. So this is a trial of drugs that, honestly, if the cancer marketplace weren't broken, we wouldn't have even pursued. And now we're going to talk about control arm, and we can talk about censoring at the end,
Yeah, that's the whole point. And do you think, let's talk about the control arm then. We'll go straight to that. And then we'll talk about those drugs and the toxicity in them. This is the same control arm that was in the PROfound study, right, wasn't it? So do you think there's kind of we got away with that in that study. So people will think that this AR targeted therapy switch thing is some sort of acceptable control arm in this current period. And this trial was around that period. And when we clearly had, obviously, docetaxel available as an option to us. So let's talk about that control arm. Why do you feel so strongly that it's substandard?
I mean, we've known it's substandard for quite some time. I'm going to read you the quote. We wrote a paper on, I call it Profoundly Bad, the Profoundly Bad study. And we write the control arm of abiraterone or enzalutamide, presumably which had not been used earlier, is suboptimal since there is substantial cross-resistance between these agents, leading to poor response rates and short PFS. I mean, it's no secret that these drugs don't work when you've exhausted the prior drug. This is well known. Now, why do they get away with it in Profound, and why have they gotten away with it in other clinical trials, and why do they get away with it in Contact-2? The U.S. Food and Drug Administration is allowing the company to use that as a control arm. The real deficiency is the US FDA. They are letting them get away with that control arm. Yeah. None of us in clinical practice would want our own father or mother to get that, or it's not mother, our father to get that drug if they progress.
It is crazy. And you make that point. I'm going to play you a clip from the podcast, Renu, because I love this one.
If your father were randomized to the control arm of this study, you would withdraw consent and pull him off that study because you'd want him to get docetaxel. So my simple ethical prerequisite to studies is if that your own mother and father were on the control arm, would you be comfortable? The purpose of a study is to have a control arm that is the best available standard of care. So much so that you feel comfortable like knowing that if your father's on the control arm, they're getting the best available proven therapy. And if they're on the experimental arm, they might be getting something better. They might be getting something worse too, and that's why we're running the study. But you can't feel like your father is getting a straw man control arm. Your father is getting purposely duped and given some lousy therapy just to eke out a trivial benefit so a company can make billions of dollars. You can't feel that.
It's totally right, because you're in the control arm, you're progressing, 40% have visceral metastases, you're going to go on a clinical trial in a big center, and you get randomized to the control arm. And, if this is your dad and you're a medic, you have some knowledge, you'll say, we're going to switch from Abby to Enza to Abby. that's what I'm going. I'm not allowed anything else. I'm going to be in that arm. You straight away feel handicapped.
I mean, it's difficult, isn't it? Because, ARPI switch has been done before, but in very
It's never worked,
selected
exactly.
patients as well, even if it has. This is a group of patients that have rapidly progressive, very poor prognosis disease. And the control arm in this trial is almost like not treating them.
And Vinay, you describe it as unethical. So, and how does this get ethical approval then, or how does it? How
That's
do
what
the FDA
is
agree these endpoints? And
boggling, yeah.
how do individual investigators say, well, I know in my practice I can just give cheap docetaxel to this patient? How do we get away with having unethical control arms?
It's a long history. I mean, you may remember that when we had ipilimumab in melanoma, they allowed nivolumab to go up against dacarbazine in a randomized trial. That's a barbaric chemotherapy that we had stopped using. It happens frequently. It's 20% of oncology studies. And the paper that you could cite is the Talal Halal paper that we did in JAM Oncology called Analysis of Control Arm Quality. Why does it happen? I think it happens because the FDA has misinterpreted their role. The FDA thinks that they just need to show a clinical trial has efficacy above an acceptable standard of care. But in the modern world, efficacy can only be against the prevailing standard of care, the standard of care in Australia or New Zealand or America. It can't be an old, antiquated standard of care. I think the way the law is written, that the FDA, if they wanted to, they could switch that and have the standard of care be the standard of care. They've chosen to interpret it in a very sort of low bar way. They want to make a lot of things available. One point I want to make here is that one of the things I heard about this study is even if you don't think cabo-atezo is the best option, at least it's another option, right? So if this gets approval, at least we'll have another tool. And if you want, you can give docetaxel, but thankfully I can also have this as an option. But here's the point I would make. We know, and this is a cross-trial comparison, that things like docetaxel, cabazitaxel, and even lutetium-177, they have PFSs around 8 to 9 months in different studies in this similar population. Maybe, almost the same population, but similar. These are cross-trial comparisons. Here, cabo-atezo is 6 months, and the control arm is 4 months. It is possible that by adding this as an option, there are going to be practitioners in the community who say, instead of docetaxel, let me try the chemo-free option, the cabo-atezo. And actually, their patients will have a shorter survival by having more options. So you can erode survival by having more options, not merely enhance survival, because you reach for the weaker option, the one with more toxicity and less benefit. So to me, just having more options, that's not a good argument. We wrote this as a paper, When More Options Erodes Outcomes by Sunny Kim. So, I think people should be very careful. Bad control arms is problematic for the people in the study and for people outside the study, because now we may be reaching for options that are worse than what we otherwise would have done.
Yeah.
And your opening point that the active arm here is a dud and it's very toxic. So clearly you point out that the way to try and show a difference is by anchoring the control arm to a very substandard level of care. And I think that's what you show in the fact that these PFSs, I know cross-trial comparisons, blah, blah, but still this is very disappointing. And you'd like to think if some of these men were getting docetaxel, there'd be a much better result. So is that an industry thing? Is that the way industry approaches these sorts of questions, is to say, okay, we've got this new agent and we got a patent and we got this. The most important thing is to make sure the control arm is going to make us look good. Is that what they think in boardrooms? Do you think, really?
Yes, it's an incentive problem. Here's why. The US FDA has decided that any amount of statistically significant benefit will qualify for approval. For instance, erlotinib in pancreas cancer was approved with a 10-day median survival benefit, but a p-value less than 0.05. So one, if you allow a company to get, it doesn't matter if it's a clinically meaningful benefit. Like, I'm not even sure a 1 point some odd month radiographic PFS is clinically meaningful, but it's statistically significant. Okay, if you allow the company to get with any statistically significant benefit, that's prerequisite 1. Prerequisite 2, how much money do cancer drugs make? Cancer drugs make about $10 to $15 billion in the life cycle of the drug on patent. These drugs are incredibly profitable. In the 1990s, people did not think a cancer drug would ever be a blockbuster drug, a drug that made more than $1 billion a year, because cancer was thought to be a collection of rare diseases. Now Pembro's on pace to make 30 billion in a year, 50 billion in a year. Pembro may be the first $1 trillion drug. So the amount of money you make from a p-value less than 0.05 is so big. The benefit you need has to just be 10 days, What the incentive for the manufacturer is just to take even dud drugs that you have on hand, run larger and larger randomized studies and more randomized studies, Because if the FDA runs, we know Sutent in adjuvant kidney cancer, some studies are negative, some are positive, but they only consider the positive ones. So if you have a system where we only take the positive results, we take any benefit, and we'll give you mountains of money if you get that P of 0.05, you're going to get a lot of trials that should never have been run in the first place. Drugs that just don't have activity, have lots of toxicity. And the industry is really like a gambler pulling the slot machine. They're just hoping for the 3 cherries, because if they get 3 cherries, they're going to get $10 billion. And it's not so hard to get 3 cherries when you get unlimited pulls, and it's, so, and that's the system we have, I think.
It's scary, isn't it, to think about the ripple effect of studies like this, eventually affecting our patients.
Yeah, and actually I'm going to play another clip from Vinay because he does a really good summary here.
Overall, I think this is literally why many people have a problem in oncology. They know that there's a lot of greed in the space and people are pushing drugs that just don't work, sucking our children's fortunes away, taking all the money from the gross domestic product to pay for these useless drugs, which don't actually benefit cancer patients. And it's entirely a financial redistribution system that takes money from everybody and puts it in the hands of elite shareholders. And all the way, the IRBs rubber stamp this, the universities rubber stamp this, they give promotions to people involved, they get to give the oral presentation. This is a broken system.
It is too, and there's a lot of responsibility there on the behalf of the regulators to approve it, because it looks to me like this is all about agreeing with the FDA beforehand, an endpoint that if you meet your endpoint, you're going to get a recommendation, which means money in the US, that if it's FDA approved, as you point out, society are going to have to pay for this. So how can that broken system be fixed? Because I reckon if there was a totally different top-down approach and the FDA were looking at these companies as they come towards them to say, this is our proposed trial, these are the endpoints. And if the FDA were saying, well, that's not going to be an appropriate control arm, we anticipate, therefore you're not allowed to do that. Or we must have investigator discretion to use stuff like chemo if necessary. That would change everything then, wouldn't it?
Yeah, I mean, there's 2 people who could change the game. One is FDA, we'll talk about them in a second. But what about the investigators? Nobody puts a gun to the head of investigators and says, you have to open this study. This is a choice that's made. And it's many of these elite US cancer centers that make this choice. They do it knowing the control arm is not what they would do. They would want docetaxel. So an investigator could go to the company and they could say, listen, I can't be the PI of your study and I can't enroll on this trial unless you say true investigator choice. Of course, you could switch Abby to Enza, but also allow me docetaxel or Kabazi and give me all the options. Let me have anything in my toolbox. They could push back. But the reason people don't is that the company will find the one investigator who doesn't push back and give them the study. They'll make them the PI. They'll get a New England Journal paper and a podium presentation. So it's really a race to the bottom. And so when I talk about these career incentives, to me, I find it tragic. I mean, as a doctor, we swore an oath when we were young, in my 21, I was 21, 22 when I started this path. We swear an oath that we're really going to do what's best for patients and society. But by the time you're in your 40s and you're running these studies, people have forgotten. I mean, most of what people do day to day is in their own best interest. And I don't necessarily blame them. We all have to preserve our jobs at some point, but we have to ask ourselves, how much will we sacrifice? Are we willing to have these control arms that, again, as I say, and as the censoring will show, people don't want to be on? Like, for instance, in vision, 56% of the people discontinued that control arm. And here, it's also a very high percentage. So to me, I think the investigators have a role. Now, the FDA. The FDA has been run by Rick Pazdur in oncology.
Exactly, and you do in the Contactor 2, and again I encourage people to go and listen to it. You do really say, look, this is a lot about people just want to get promoted and this and that. And look, again, people will say that's harsh, Vinay. A lot of people are genuinely trying to get involved in academic studies to do this, that, the other. So I think there's a balance in that.
Definitely.
But I think it's the industry, the overarching industry thing, and how the industry relates to FDA people. It seems to me you're an FDA commissioner, and then you're not. You're an extremely well-paid consultant, whether it's for this industry or that industry. So there's a kind of a grubby environment, I think, in which some of this world goes
But
wrong.
I take Vinay's point that as clinicians, it is up to us to make sure the right message gets out there, even if these trials are run.
Like investigators.
Yeah.
Exactly. Before we talk about keynote, we want to talk about the censoring, because you made and Renu, you were very impressed. There's a really technical aspect of the censoring that Vinay dives into in the podcast.
And you've done a lot of work on this, Vinay, and recently published a paper about censoring of data and how it can still be informative. Give us your insights on that and how it may have affected the results from Contact-02.
Yeah, I mean, I guess for the listener who may not even know what we're talking about, let's say, what is censoring? Censoring means that, like, every time you look at a Kaplan-Meier plot, what do you see? You don't see the outcomes of everybody who enrolled at 30 months and 36 months, because some people on that study only enrolled 2 months ago or 4 months ago. So at 4 months, if you enrolled and you didn't have progression, what do I do to that person at month 5 and 6 and 7? I just don't know what happens because that's in the future. And so we censor that patient. In other words, we omit that data point, that person's data, and we take the people who we did follow for 6 months or 8 months or 10 months, and we average that data as if it happened to everybody. In other words, we take information from people we have and followed and assumed that had everyone lived longer, they would have had the same kind of probability of good or bad outcomes. Right. And that is the fundamental assumption of a Kaplan-Meier plot, that the censored patients, the people who we lose follow-up to, are no healthier, wealthier, or wise than those in whom we retain follow-up.
Right.
Now, there's a couple of ways in which this assumption, might be distorted. If the censored patients are all going to do worse than the people who you follow, then actually your curve is better than what it would be if you included everybody. If the censored patients were going to do better than the people you followed, your curve is worse. So one thing to look for in these Kaplan-Meier plots is how many people are censored very early. And in CONTACT-2, lots of people are censored at the very first time point, which I think is either 3 months or 8 weeks or something like that. Some very early time point. It's like 12 or 15% of people are censored. Is that because they all enrolled in the last 12 weeks? I think that's probably unlikely. I think they didn't have this bolus of enrollment in the last few weeks. I think what's more likely to be the case is there are different reasons you're losing people on these two arms. In the treat interventional arm of cabo-atezo, people are dropping out. They're not following up with scans. I suspect those people are people who are facing really toxicity. They don't feel good. They don't want to come in for the scans. They're feeling weak and vulnerable. And those people are probably going to do worse than the average person. So you censor the weak from one arm. In the other arm, the control arm, which I think is, like many of us had said, if you were well connected, you wouldn't have allowed your father to go there. The people who are censored, it's also very high. It's like 11%. Who are these people? These aren't people having toxicity, I think, because these drugs, Enza and Abi, are relatively, better. Their toxicity profile is better, even if they don't work so well in this setting. These are people who I think are wealthy, well-connected. They know that this control arm is not that good and they can get docetaxel. And these are people you're losing to follow-up who might be doing better than the people you're measuring the outcome in. So I suspect in this study, you have equal rates of censoring, roughly, but there's different reasons why they're censored, and that creates a huge bias to pull the two curves apart, even when no difference exists. And we have a paper out right now in the European Journal of Cancer called Equal Censoring, but Still Informative, when the reasons for censoring differ between treatment arms. And we talk about CONTACT-2 as just a kind of a ripe example. The last thing I'd say is one way to know for sure is to have access to all the raw data, et cetera. And, and that's, of course, what we don't have because the companies hold that data.
Excellent. I think that's so right, because when you look at the curves, you think, oh yeah, the censoring's about the same. It seems to be high, 10 or 11% at 3 months. But you're pointing out that it's different reasons which will create more bias in the arms.
And already when the difference is as low as 2 months, with the radiographic PFS, when you bring this element into it, you do wonder.
So that's an important point. That's a very important point, is that when you take marginal differences in PFS that are coupled with no clear improvements in OS, and you start to have a little bit of censoring, it doesn't take much to tip the whole plot. And we've done a number of papers with Oussama Bilal and Timothy Olivier, where we've shown what is the tipping point where there's actually a null result that you're creating an entire effect out of just censoring. And so I think that's an astute point. A small PFS is very likely to be the case.
Wow.
Before we go on, you were at ASCO GU, so how did you feel it went down on the ground, CONTACT-02? Because my take on it was when I saw it, I went, oh, it's interesting. I'm skeptical about those drugs anyway. And I thought the control arm was a dud. We knew that beforehand, but what was the reaction like?
It was mixed reactions. We people appreciated the trial, and like Vinay said, a lot of it was having another weapon in the armamentarium of the fight against MCRPC. But a lot of these points were brought up in the discussion. I thought Kim Chi did a fantastic job putting it all into perspective. And at the end of the day, we're seeing a small radiographic PFS benefit, but is it really clinically meaningful? And, Kim Chi's conclusion really was that at this point in time, probably not.
I'm going to play you another bit from Vinay's podcast where he's looking at some of the reaction, because I was asking you for reaction, and the reaction on Twitter that I saw was, oh, this is all fantastic. But actually, you were saying over coffee when you're talking to people, there was a bit of, I think, control arm stuff.
Definitely.
Really, is this the best we can do? But here's a bit more reaction.
People are happy to lavish praise on the investigators. Let me read you some things that actual GU oncologists who are supposed to be experts in this space say. Outstanding presentation, as always, by the prostate cancer master. the first author of the study. Important context for CONTACT-2 findings. Cabo-atezo versus second-line NHT was studied in a highly selected population with measurable extrapelvic blah, blah, blah. Okay, they're just summarizing what it is. But outstanding presentation. The master. Are you really a master when you run an unethical study? This person writes, a great talk from the lead author presenting CONTACT-2 with improved PFS. Even though modest difference, it's important to increase treatment options in refractory prostate cancer. No, it's not. If there's 3 good options that have an 8-month benefit and you add one with a 6-month benefit and people switch to it, you're actually worsening outcomes for the overall pot of people. So sometimes having more options erodes outcomes. This is a talking point that the pharmaceutical industry has told you in their drug dinners that you have imbibed and you're regurgitating that you haven't thought about for 30 seconds. It's not good to have options worse than the options that are already there. That's just totally brain dead. And I don't know why people keep saying that.
Oh.
I mean, I'm nodding and agreeing, but if you actually watch those video versions, you'll see the names of the tweets
yeah.
are there.
And the people that we know very well
brain dead.
have a lot of respect for.
I wouldn't call that particular person brain dead. So again, we've discussed this early on, the inflammatory communication style.
The only thing I'd add is that, like, I'm on some group chats where there's lots of oncologists on it, and there's this culture of ass kissing on Twitter. That's what it is. When you just keep praising the same big names who are on all the same papers. And I think people do it in part because they think they get ahead in career and they can network. And I don't know why they do it, but there are a lot of people who they don't like seeing it. I'm on all these group texts where every time it's like, look at this person just totally kissing his ass. And this paper is really bad. Nobody wants to say it. And so, I mean, I think at the end of the day, I say, again, what is worse? Hundreds of people were randomized to a control arm that really wasn't fair to them. I mean, they died. They had visceral disease, sometimes maybe even explosive visceral disease. They're going to die sooner because they didn't get docetaxel. That's bad. I mean, that's a real human crime, I think. And of course, some people want to, talk about tone. I think what actually happened in the study is way worse. And we need to talk about that. And I don't know. And kissing ass and stuff. I mean, I don't know. If that gets you ahead in your career, it's no career worth having, if you ask me.
Well, there you go. And we might wait for the paper, but we will invite Neeraj, who again is a friend of the podcast. You interviewed him on your podcast last week, actually.
We love Neeraj,
who presented this as the PI. When the paper is published, we'll give it a good fair hearing, and hopefully Neeraj will come and join us. The other study, Keynote 564, we dived into this before because we were quite critical and skeptical when this originally read out before the OS a couple of years ago. And we invited Tony Choueiri on with Alex Kudakov. And, we were very critical, saying, this is a real surgical population. These are patients who've had a nephrectomy and they're deemed to be at higher risk of recurrence. And so it's the adjuvant setting. And for us surgeons, we're interested in this setting because, sometimes you have really ugly looking pathology and you say, come on, is there nothing we can offer this patient? So the adjuvant space has been interesting for years, but there hasn't been a really well accepted standard of care. So what about Pembro in this setting? And when the original data read out, there was a huge cheerleading, as you'd call it, Vinay. I remembered, this is game changing. We were going, we need to see OS. If you're going to give everybody freaking expensive IO agent, toxic drug, which works in the metastatic setting, especially with combinations, you really need to know there's an OS benefit if every one of these patients, because we have lots of them, is going to get it. So we said, wait for OS, and we had a good, robust podcast with Tony Choueiri about it. And then, a press release comes a couple of months ago. It's coming at ASCO GU, big plenary, OS. So, I must say that
truly the highlight of ASCO GU.
It was the biggest thing. It's an OS thing, and it was 38% OS benefit. So I think still, I find it less, we therefore are going to have a podcast with Tony about that in a few weeks, and we'll reflect on the OS.
And what it makes it even more significant is that it's the only trial to show this benefit.
Well, why is that? Might be the question. There are other trials that did not show a benefit, as Vinay pointed out. So you dedicated a podcast just last week to revisiting this, and I know you did it the first time around. I'm going to play another clip because I love playing Vinay's clips. I think watching his reaction, he's enjoying listening to himself back. Here's one where he's talking about some of the reaction on social media.
This person writes, this is a famous person. This is the person who's behind one of the original prognostic indices in RCC. Keynote 564 is huge. Sounds like Trump. 38% OS difference, which solidifies Pembro's position in the adjuvant setting. In the placebo group, 70% of patients had subsequent IO, which is good. Oh, is it good? And is it 70%? We'll come back to that. That's another way of lying with numbers because that's a very dishonest percentage there.
Now,
That's a really good point.
It's good, but what about the Trump thing?
Oh, yeah, I know.
Because some people will say, oh, come on.
Well,
this is a very good urologist, very nice doctor.
You know, you've hit the pinnacle of your career when you're compared to Donald Trump.
I know. Well, I would never say that particular urologist is Trump-like. I have other, we all know urologists who are Trump-like, but I don't.
Huge benefit.
That's not the point I said was great. The point is about the data, right? The 70%. Is it really 70%?
Yeah,
and
so
that's a really good point.
We don't have as much time to go into this, but I want to talk to you about that because that's really, really important. That's an incredibly important point because, again, it's about the control arm. So let's say we're urologists. We have lots of these patients, Vinay. We're worried about the ones that progress, but we are reassured nowadays by the fact that when patients relapse after a nephrectomy for kidney cancer, we have fabulous options for these patients in the metastatic setting. They're going to be detected quite early. They've had a nephrectomy already. So here we go, some metastases. And combination IOs, multiple of them over the past 5-6 years have shown a really, really good benefit. So this is a very high standard of care. And therefore, I suppose the idea of offering like single agent IO in this setting is important, but you'd like to presume that if you're going to do that, if you're going to have an adjuvant trial where everyone's getting Pembro up front, that the control arm will be, comparative. And isn't this the whole point of this criticism is that, and we had the same thing the first time around, but now that there's OS, we have to look more carefully at the control arm. And as you read out in that tweet, people were celebrating after this because they'd looked at the tables in the presentation and said, wow, look at that. In the control arm, 70%. Got IO on progression. So, and then you hint at the start of the podcast and dive into it later that it's not 70%. So please talk to us about that.
Okay, so a couple points. One point is I think we have to remember in the adjuvant setting, the bar is higher because at least half these people may be cured already. That's right. They don't need anything. Yeah. They're already cured and they can only get toxicity of pembrolizumab, no benefit. They can get some thyroiditis or they can get some autoimmune disease. So colitis, for instance, these are not that rare and they're real toxicity. So the bar has to be very high. It should be OS. The next point I want to make, when we talk about cytotoxic drugs in bladder or even lung or colon, we know that cytotoxic drugs cannot have a durable remission in the metastatic setting, like the disease will always come back. But if you give them early in the adjuvant setting, you can increase the curative fraction. That's a property of cytotoxic drugs. That's true in lung and colon cancer and even bladder cancer, okay? But checkpoint inhibitors like PD-1 drugs, we know that they have a durable remission in both settings. They may have a durable remission in the adjuvant setting, but also durable in the metastatic setting. So that really changes things a little bit. And what that means is what you really want to test is the routine adjuvant administration of Pembro better than watching everybody carefully and the moment people have recurrence, giving them some doublet that includes a checkpoint inhibitor, which is the standard of care for most of the time this trial was run. Pembro Axi, Pembro Lenvatinib, Nivo Ipi, whatever you want. It all has a checkpoint inhibitor in it. The actual percentage of people who relapsed, who got a checkpoint inhibitor is 48% in this study. That means half of people who relapsed never got a checkpoint inhibitor. That to me is we're not even talking about first line metastatic RCC, even second line where it was the standard of care for a long time now to give a checkpoint inhibitor when Nivo beat everolimus many years ago. So these people in the control arm are basically getting, I think, a very low standard of care upon disease relapse. And if that's the case, how much of the overall survival benefit is due to the adjuvant Pembro and how much of it is due to harming the control arm because they never got to see pembrolizumab for the rest of their lives? And I don't know the answer to that question. And so to me, it's a very costly thing that turns healthy people who are cured into patients. And I don't have a clear understanding of what the OS would be had 100% of people at relapse gotten a checkpoint inhibitor.
2 points I have about it is that because half the patients never relapse and they're cured, that bar, as you said, has to be very high. And what kills me a little bit sometimes is, when you have patients on study like this and it's predictable toxicity or manageable toxicity, because people like yourself are very used to managing patients with these powerful drugs. But for us, hang on, that patient's in hospital all the time with his or her bowel enteritis thing. And we've had to employ a whole pile of gastroenterologists in our cancer center just to manage the side effects of IO. And it works great in many other disease areas. But in these patients who have a 50% chance of being cured, it's difficult for us to accept that. So that's the first point I'll make, which is why I'm still, concerned about this study. But the second point is that, of the ones who relapse, you'd like to think it. But can I ask you to explain why they didn't get it? Is it, number one, because this study was open just as that era was starting? I think you point out it's like 2017 to 2019 they were recruiting. Pembro Axi came in 2019 in the US. So maybe there's a period where people were relapsing before that standard of care emerged. So that will be a proportion. I think it's a small proportion. Or second, is it, as you hint at, that it's because this is an international multi-center study and loads of the sites where they're getting the adjuvant Pembro, because they're on this drug-sponsored study, pharma-sponsored study, they don't have access to funded IO in that country. So when they progress, it's not counted for. And it should be in the study. The same company that sponsored should be saying, we're also going to sponsor, a standard of care here that maybe is not affordable in your country. So can I ask you to, explain why only half get it?
It's probably all the second reason. And here's why it's not the first. Because one, the time span is short. So you have to both relapse and have time, and then, so that very few people will have been in that window. The next point is that they should at least get pembrolizumab second line, because nivolumab and pembrolizumab were already approved as a second line agent in RCC at the time the study was launched, So they should be getting it at some point post-progression care. They're not getting it ever. Now, why is the real reason? If you look across all of these studies where post-progression care is not the US or Australian or New Zealand standard, it's because of the multi-center nature. These trials run in many places in the world that are low and middle income countries that through no fault of their own cannot afford pembrolizumab in the metastatic disease setting. But imagine if you give them the results of this study, they definitely can't afford pembrolizumab in the adjuvant setting. You're not helping anyone in that country by running it in that country, because if they can't afford it in second-line RCC and not in first-line RCC and metastatic disease, they cannot afford it in adjuvant setting. Meanwhile, the people in the US, we can't look at this data and extrapolate it to our practice because we give pembrolizumab in the front line. We give pembrolizumab and pembrolizumab all the time. So we don't know if this trial is applicable to us. So it's these international trials that neither help us in the US and Australia and New Zealand, nor do they help people globally. They just kind of take advantage of this quirk of economic disadvantage. And the last point I'd say is the solution is easy. The company that's giving Pembro makes Pembro. It doesn't even cost them the actual market price to make Pembro. It probably costs them $5,000, $3,000, a year to make pembrolizumab. It's a monoclonal antibody, but they probably make it at scale. They could provide everybody in the control arm who relapses pembrolizumab. In addition to a TKI, they can pay for that. It won't cost them that much money. It's a tax write-off, and it would answer the question for people in the study.
And do you think investigators then should be pushing for that? They should say, we see this study, however, what we need to do for ethical reasons is say in the control arm, everyone is going to get the same drug on progression in every country, provided, it will be approved in those countries, but it won't be funded. That's usually the barriers that, it takes quite a long time to get funded in many countries. So should investigators be pushing harder to say for fairness? Because you can see why if I'm not a medic, but I'm the chief financial officer of one of these companies, I'll say, no, that doesn't sound like a good idea to me. Yeah. You mean that's going to improve the outcome in the control arm? And, maybe we're being, we're all getting taken away with cynicism now, but that's okay. A bit of cynicism is okay looking at these studies. There's so much money involved.
But
there
it's
are lots of people who work at these companies, but we're the doctors, and I think the same thing is true as in Contact 2. The investigator can say, I don't like the control arm. The investigator can say, look, if you want me to run this adjuvant study, you've got to give me Pembro to deliver to the control arm at progression. So one, we ask the scientifically valid question, and two, we do the right thing for people on the control arm who are progressing, in whom we know checkpoint inhibitors have a benefit in the metastatic setting. So let me do that. It won't cost you that much more. It really won't cost them that much more compared to all the operational costs of the study. It's the right thing to do for patients, and we're the doctors. We should be pushing for what's best for people, and I think that's the only solution, that we should say, until you do that, I'm not going to put my name on that study, and good luck,
It's a shame, isn't it? Because, when you are comparing a group of people, all of whom who are getting this adjuvant treatment, 50% of those who don't need it, you want to at least be comparing it to a group of people who get the drug when they really, really need it.
And look, when the paper comes out and the subs come out, Vinay and co are very good. They go straight into that side of it. And we will do a podcast. Tony's already indicated he wants to come back, and we'll be able to say, we had Vinay on to talk about it, and we'll play a few clips of him as well. But okay, the reason we loved having you back on today is we agree that we need to ask harder questions about all of this to make sure we're doing good science and good things for our patients. But all I will still say is, I think there are some very good people involved in some of these studies, and perhaps some of Vinay's criticisms, I wouldn't personally use the same language, but I think I worry about those. I think sometimes people use that as a smokescreen to say Vinay Prasad is blah 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 blah, And it's a smokescreen for, but the stuff he's pointing out is real. These are real criticisms. And so sometimes it may not actually work in our favor that people don't address the actual valid criticisms and the many papers Vinay and his group have published about control arms and about censoring and so on. But yeah.
I just want to make one point here about I actually think that the people involved are all good people. But if you look at the history of the last 100 years of medicine, there are many, many studies run that we look back on and we say, my God, how did we allow that to run? The control arms were dubious. What we did to participants was cruel. There wasn't informed consent. Two things can be true. The people who did those studies, they're not bad people either in the 1960s or 70s. At the same time, you can look back on that and you can say those trials were unethical and we can do better going forward. Similarly, the people who run these studies, they're not bad people. I don't think so. The incentives are so bad, they're encouraged to make the bad choice. But 50 years from now, they have to ask themselves, what do they want their legacy to be? People will look back and they'll see there'll be a very big paper trail that when these studies were run, it's not just me. There's 10 other people who are, or 20 other people who make these criticisms, lots of editorials being written. They're going to see the paper trail. And so you have to ask yourself as an investigator, 50 years from now, do you want your legacy to be the same as it was for all these people throughout medical history who ran studies that now we look at and we smack ourselves and say, gosh, we really shouldn't have allowed that to happen. This is their opportunity, I think. So I hope they take it.
So Vinay, apart from Plenary Session, are you thinking of introducing a new podcast series called Unethical Trials?
That's not a bad one. Plenary Session to some degree is mostly
also known
also known as Unethical Trials. In my mind, the problems with trials are the control arm, the post-protocol, the endpoint isn't really what matters to people. Sometimes the non-inferiority stuff doesn't make sense. The way the drug dosing doesn't make sense. And I think if people want to get a list of what are the biggest problems in cancer trials, I think I'd turn them to the book Malignant because, we document them all in there.
And look, we'll put links to all of those in the podcast. We're very grateful to you for coming on. I think for listeners and viewers of GU Cast, we are mostly a GU oncology podcast, but we have a lot of lay people listen, industry people listen, a lot of urologists, radiation oncologists. It's different to some of the big pure oncology podcasts. And what I'd say to you all is, open your minds to this. I think it's important not to just be overwhelmed by the press release to the stock exchange and the cheerleading on Twitter. It's important to listen to critical minds, and that's why I really encourage people to
information.
Listen to people like Vinay and their colleagues, and you don't have to agree with everything, but open your minds and hear the argument. Is the way I'd say. So thank you, Vinay, again very much for coming on.
Vinay.
And keep up the good work.
Thanks for having me.
So updated Vinay Prasad, February 2024. What did you make of that?
Yeah, it was enjoyable. It was just what I expected it would be.
Unrestrained, unrepentive.
Do you think he'll change his style of communicating?
I mean, I did ask. I think it's part of his shtick. It's part of his style. I mean, he has a massive, massive following.
Yeah.
And I think it is. I mean, certainly, I think the reason I follow him is I do enjoy listening to his critique. But maybe some people just follow him for his style and his.
Well, I think for a lot of his followers, it does offer some entertainment value. But I mean, I guess our concern really would be that we hope that it doesn't mask some of the important messages that he does have to give to the medical community. But he just the way he does it is probably not the sort of style that you and I would have,
Yeah, and I personally don't enjoy reading some of the way he talks about people, and I can see why, as we spoke about with Vinay, why good people we like Scott Eggener will describe him as blustery, obnoxious and condescending, self-serving, etc. I can see why people...
That's just a selection of the words that Vinay would use to describe other people, isn't it?
It's true. But, do we really need that in academic medicine and oncology? I don't know. I personally don't, and I think it's very harsh, really, some of the language he uses.
The personal attacks are not good.
Don't like that. Don't approve of that, and but I do think he makes really good points about control arms and about industry, and we're grateful to industry. Industry supports us, but we want to have open and frank conversations and open minds about these things. So I thought it was good to have him on. Yeah,
it's always interesting to hear his point of view, and I'm sure that's not the last time we'll hear about unethical trials from Vinay Prasad.
Yeah, I'm sure it's not. So anyway, if you've stuck this late in the podcast, hopefully
please don't unfollow us.
Don't follow us, and hopefully you did enjoy it a little bit or get something out of it. There is a role for open, challenging, and discussions in this. It's an important thing, oncology, getting it right and thinking about best things for patients. And
it does seem like Vinay can take it as much as he can deal it. So if you do have any issues, be vocal about it.
Thank you.